Hello and welcome to ID Talk, answers from an infectious disease expert. I'm Dr. Sean Elliott, a pediatric infectious disease specialist with Tucson Medical Center, professor emeritus of pediatrics at the University of Arizona College of Medicine, and medical director of infectious diseases and immunizations at the Arizona chapter of the American Academy of Pediatrics. This podcast has been created to answer questions from our chapter's members about the COVID-19 pandemic and about pretty much anything else related to infectious diseases, infection prevention, and vaccinations. This is the first week of April, and for those who are celebrating, good Passover, happy Passover, and happy Easter. It's been, again, an exciting several weeks since we last spoke by podcast in terms of respiratory illnesses, which are still out there, of course, still causing varying degrees of bronchiolitis and croup, although RSV thankfully seems to be trending down significantly, with just a smattering still of parainfluenzas, enteroviruses, etc. As respiratory viruses slightly trend down, of course, the viral gastroenteritis are trending up. And so many patients in the emergency departments with acute gastroenteritis, emesis, diarrhea, etc. And the two principal viruses still being seen are norovirus principally and some rotavirus as well. So yes, the emergency departments are busy. I'm sure all of you are as well. This week we have some, again, great questions of a variety of topics. The first one is COVID related, and the questioner asks, after the most recent FDA approval of the COVID-19 booster vaccine, and presumably referencing the bivalent boosters from Moderna and Pfizer, will we see an increase in children vaccinated in the age group of age 5 years and under? Wow, I wish I could predict this. My general suspicion is that probably no, with a whole bunch of factors which many of you I'm sure are quite familiar with: continued vaccine hesitancy, continued vaccine and COVID fatigue, and also realistically everyone's awareness that COVID-19 as a life-threatening illness has largely faded out into endemic status, and there just isn't that sense of urgency for everybody to be vaccinated. This is adults all the way down to children and infants. So as per FDA and CDC, indeed, the bivalent boosters can be used as boosters in pediatric patients, assuming that under age 5, that they have completed their primary series with the original monovalent vaccines. So, well, are we going to see any increase in those numbers going forward? I think that's going to be an individual basis. Certainly, we can use our motivational interviewing techniques to provide that. I do think it is a good idea to proceed with bivalent vaccination. On the other hand, we're currently between many surges. There's not a huge amount of COVID or SARS coronavirus 2 out there in terms of new serotypes, new vaccine strains, new mutations. There is yet another XBB subvariant of Omicron, which is being found in the country of India and some small cases in the United Kingdom. But here in the States, we're still at the same current trends with what we had been seeing without any significant increase in those numbers or in infectiousness or in severity. So it may actually be reasonable to hold off and wait for perhaps a broader coverage vaccine, and these are being worked on, sort of the universal SARS coronavirus 2 vaccine, and or also to wait and see if the combination of influenza and SARS coronavirus 2 vaccine products that we discussed last time, to see if those gain steam and are actually able to be researched, safety tested, and to demonstrate efficacy. So I think, quite honestly, if we take a passive approach to vaccination for COVID-19 under age 5 years, we are not going to see an increase in vaccination uptake. If we are active in this, that there may be a slight increase, but I don't anticipate that anyone anywhere is going to see any major changes until and or if we settle into annual vaccination strategy, and that is likely to occur. We're just sort of waiting to see with what products and when CDC and the Advisory Committee on Immunization Practices, the ACIP, might advise exactly that. So stay tuned for that. Great question. I don't, unfortunately, have a crystal ball to really predict how this is going to play out. Question 2. In recent publication, it was reported that outpatient antibiotic prescribing was down significantly in the year 2020. So I think this is a trend we will continue to see. Importantly, we have to go back and look at what was happening in pediatric infectious diseases in 2020, which, as you recall, was when COVID-19 was surging in its first iteration across this country. Remember also that the World Health Organization, WHO, declared a worldwide pandemic on March 11th of that year. And in the States, we were seeing cases increasing rapidly to the first major surge. You may also recall, and now this is a couple years ago, but we've talked about this also in the podcast, that the rates of routine pediatric infectious diseases which were not COVID-19 basically flatlined. There were no cases. RSV disappeared. Group A streptococcal pharyngitis disappeared. Bronchiolitis gone. UTI pylos, unless they were associated with COVID-19, pretty much gone. So the indications for reasonable prescribing practices for outpatient antibiotics had largely stopped occurring because everybody was sheltering in place and we had barrier protections with masks and in some cases gowns and gloves. So I think that that publication may actually have, instead of documenting a intentional trend in decreasing antibiotic prescribing, was actually just documenting a needs-based or decrease of needs-based prescribing practices. So it's not a trend that I expect that we will continue to see. Certainly, all those infections previously named have had a major resurgence. We are seeing a blossoming of invasive and non-invasive group A streptococcal disease, a fair number of strep pharyngitises, a fair number of scarlet fevers, and even now rheumatic fever as well. So we are definitely seeing a return of the routine infections. And of course, as with our most recent several months of significant respiratory viruses, RSV, rhinoentero, adenovirus, paraflus, all of those, of course, are highly associated with secondary bacterial infections such as acute otitis media and pneumonia. So I think if one were to take a snapshot even in the last couple months, we would see a return to normal, if you will, of antibiotic prescribing. So sadly, it's not a trend we'll continue to see. I think as we intentionally prescribe antibiotics, the need for those is definitely existing. And in terms of antibiotic stewardship, we can continue to advocate for limiting of antibiotic use, but sometimes you got to use them. So sadly, and that's a long-winded answer, this is not a trend that I think we'll continue to see. Darn it. All right, question number 3. This is fantastic. So in a recent CDC report, babesiosis cases are rising in 8 states and newly endemic in 3 more. How does babesiosis differ from other parasitic infectious diseases such as Lyme disease? So keep in mind that many of the vector-associated infectious diseases such as Lyme disease, such as anaplasmosis, Rocky Mountain spotted fever, all of those are caused by a variety of both spirochetal bacteria and organisms which sort of cross boundaries between bacteria and parasitic disease. Babesia microti, is an intra-erythrocytic, so an internal red cell parasite, if you will, or infectious disease transmitted by the Ixodes scapularis tick. So certainly our dear tick friend, which does distribute Lyme disease in endemic parts of the country, same tick vector can also distribute babesiosis. So in terms of epidemiology, even with newly endemic parts of the country, the overlap between babesiosis and Lyme disease is identical, although Lyme disease is far more prevalent in far more states and far more regions of the United States than is babesiosis so far. So there's that as a slight help. Babesiosis currently is being described in the upper Midwest, especially northern Wisconsin and Minnesota, and then, of course, the eastern seaboard, which is the most dense distribution of Lyme disease as well. So how does babesiosis differ? Unfortunately, clinically, not by much. So a typical babesiosis case is going to present initially with fever and rigors, myalgias, some sweats and headache, and then sort of malaise/anorexia. So very much an indolent, flu-like, non-specific presentation, which is exactly like you might see with Lyme disease or a first day or so of Rocky Mountain spotted fever or, any other virus, name your poison. So there's no significant clinical differences there. One important difference, however, which distinguishes babesiosis and Lyme disease is that primary or first stage Lyme disease will typically present with the classic erythema chronica migrans rash. Babesiosis is not associated with the rash. Great, wonderful, because unfortunately, a fair number of Lyme disease primary rashes are not that significant, not that visible, and certainly patients have been diagnosed with and been treated for Lyme disease in the absence of finding the characteristic rash. That's not a major distinction, unfortunately. Babesiosis, if unrecognized, or even if it is recognized, can progress to multi-organ dysfunction syndrome. So severe anemia, acute respiratory distress syndrome, DIC, congestive heart failure, kidney, liver failure, shock, splenic infarct, you name it. And because it is an intraerythrocytic organism, the hemolytic anemia and downstream effects of that are the most prominent. So a patient with Lyme disease typically won't progress to such a multi-system failure and shock type illness, but we're not going to know that in the early days. So there is not a whole awful lot, unfortunately, to help us differentiate other than potentially the failure or progression and perhaps distribution, meaning that we're not seeing babesiosis so far, knock on wood, here in the Southwest. We're technically not seeing Lyme disease either because we don't have the Ixodes scapularis tick here. However, there have been cases imported, of course, and there have been several cases that are truly serologically confirmed for Lyme disease that had no travel history outside of Arizona or coastal California, neither which is known to carry Lyme disease. So, as we found with Rocky Mountain spotted fever, I caution us against saying it'll never happen here because Rocky Mountain spotted fever was not supposed to happen in Arizona, and yet we first demonstrated cases in 2003 with a new or a novel tick vector, that being Rhipicephalus sanguineus, the Arizona brown dog tick. Unfortunately, there's not a great answer to this question. There is not a clinical difference initially, and diagnostically, of course, we can look for both serologically, so doing antibody testing, and or looking for the organism on a blood smear similar to how we look for malaria. So keep babesiosis in the back of your head. One additional concern, because again it's intraerythrocytic, there is a significant number of cases that are transmitted by transfusion. So transfusion, either blood transfusion like packed red blood cells, or solid organ transplantation, or even potentially perinatally, vertical transmission from mother to fetus. So it is possible that we may see babesiosis cases here in Arizona if they are a recipient of a infected or contaminated blood transfusion, potentially. So do keep it in the back of your head as a differential, and can certainly chat with your friendly local infectious disease provider and or send serologies for babesia, and keeping in mind that somebody may have been infected previously, especially if they grew up or were living on the East Coast, and a positive antibody test does not confirm active or acute disease. So again, most likely we will be talking if you get a suspicion of a babesiosis case. All right, next question. This questioner asked about an article that discusses the newly created messenger RNA anti-tuberculosis vaccine that's coming to us from University of South Africa in Cape Town. And the question is, what could this mean for the future of TB? Well, as we've discussed previously, the whole scientific concept of messenger RNA vaccines has had a huge proof of concept in the COVID-19 pandemic. This is a powerful platform in which to build vaccines, and it is a certainly promising vaccine to have an mRNA TB vaccine. The two slight caveats. The first is that the same platform has been explored in vaccination against HIV, which has been a terribly difficult virus to get protective response from with vaccine. The mRNA vaccine platforms attempted for HIV vaccination so far have proved underwhelming in their response, either as a pre-exposure approach, sort of like PrEP, and also in trying to build immunologic treatment of an actively acutely infected HIV patient. So there's no guarantee that the important work occurring in South Africa is going to come to a successful conclusion. The other caveat, unfortunately, is that to prove concept of an mRNA vaccine against TB, that vaccine needs to be further delivered and then, importantly, tested in phase 1, 2, and 3 safety studies and efficacy studies. And to do that requires funding. Well, guess what is not being funded internationally? That mRNA TB vaccine. So far, the research has been done very locally with local sources of funds. The Bill and Melinda Gates Foundation thankfully has taken this up as a cause and is advocating for, I don't want to say chump change, but to the Gates Foundation, $800 million to carry this vaccine into its important and critically necessary phase 1, 2, and 3 vaccine trials. So this promise of discovering funding through the Gates Foundation is coming to us from just 3 days ago. I hope that is taken up. I hope that the mRNA vaccine against TB does gain traction, and of course that it is demonstrated to work. If so, and if the world decides that TB is a worthwhile cause to try and immunize the world, and if funding is further delivered to make that happen, then we might actually get a handle on TB transmission worldwide. Certainly the vaccine has the potential to do that. I think, however, those of us who have followed the socioeconomic and political trends of COVID-19 vaccination realize that third world countries where the vaccines are most critically necessary will be the last to receive that vaccine and unlikely to receive it in any sort of significant funded way. So I hope that this turns out to be a cynical and wrong opinion of what's to happen, but at least recent history has demonstrated that that is a true concern. So if the vaccine works, fabulous. If it gets distributed to the world, fabulous. That would be awesome, and that would very likely eradicate or reduce tuberculosis to a rare event. That would be awesome. The reality is that may or may not happen. And then the last question, sort of on a TB theme, is what factors have contributed to tuberculosis levels being back up to pre-pandemic levels? Great question. I think we could as easily apply that question to every other respiratory transmitted infectious disease, all of which have rebounded to pre-pandemic levels. And the simple explanation is we have come out from behind the mask. We have started congregating together. We have started sharing airspace together. Respiratory droplet transmission of all respiratory infectious pathogens has of course increased precipitously, and TB is just one of many that we've seen. So that's a short and sweet answer, which is unfortunately not something we can do much about unless we somehow go back to a state in the world where everyone masks. I think you'll share with me my cynicism that that is probably not going to happen, unfortunately. In terms of direct threat, however, to pediatric patients and also in the United States, the same endemicity and epidemic trends hold true. So in general in the United States, with the exception of some very dense intra-urban and typically lower resource populations, the transmission and risk of becoming positive for tuberculosis is really quite rare. Now, of course, we here in Arizona, courtesy of being a border state, do have higher rates of TB, typically acquired either in other parts of the world or certainly across the border, and then immigrated or transported across the border into Arizona. And so we, of course, have more rigorous and conservative interpretations of the transdermal skin test, the PPD, and or a positive quantiferin TB testing. So yes, we should still be, as we were pre-pandemic, screening for TB as we would with any other high-risk population, not saying that every child in Arizona needs screening, but just considering risks living either right along the border or in the counties bordering Mexico and or travel history across the border and or international immigration. So there you go, a fun hodgepodge of questions, and keep those questions coming. Again, it's fascinating to think about what else is out there. In the meantime, though, thank you for listening to ID Talk. Arizona AAP members can submit questions for future episodes to covid@azaap.org. The Arizona AAP chapter would like to acknowledge the generous support of this podcast by the Arizona Department of Health Services through the Title V Maternal and Child Health Services Block Grant funding. For more information and resources related to COVID-19 in Arizona, or to learn how to become a member, please visit us at azaap.org. And in the meantime, and as always, thank you for your service. Hang in there, keep fighting the good fight, and we'll talk again soon.